Okay. Let's see, where's my shared screen here? Okay. All right, everyone. I'm still trying to take care of some technical difficulties here. Oh, well, looks like I'm shared. Don't know why this is coming up. So I'm hitting the wrong button. Let's see. Oh, how do I widen the screen? That's what I want to do. Well, let's go to stop share. Let's stop share, and then let's try resharing. There we go. Share. And let's try to put this. There we go. Okay. All right. I think the last time that I saw you, I was just talking about kidney basics. And last week, I think it was, Dr. Buka came in, and um, well, the kidneys being the nemesis of the heart. And in a sense, that is true from a lot of different standpoints. But, and then I think in the coming weeks, Terry's going to carry on, and she's going to talk a little bit about lab values and which ones are important regarding the kidneys and regarding your urinalysis, what's found in the urine, and why some of those constituents are very important, especially if they're high, very high, or very low. So I'm going to talk about a couple of conditions in particular. And the reason why I'm not going to go all over the place with that is there's just so much regarding kidney disease and kidney illness that, one could do a separate PowerPoint on either one. But as I was reading one of the resources that helped prep me for this talk today, I realized that one's own fluid status seems to be a very important issue, or a very important aspect to how problems with the kidneys begin. So I'm going to focus mainly on two things. One is a urinary tract infection, and the other one is the start of acute kidney injury, because those two seem to be seen probably most often in the elderly than any of the others. We could talk about kidney stones. We could talk about benign prostatic hypertrophy. We could talk about pyelonephritis, but no, I think we'll stick with these two and expand on them this morning best we can. So the chart you see up here has by age groups the prevalence of chronic kidney disease, all the way to from 18 to past 60. And as you can see, the prevalence of kidney disease and kidney illness skyrockets after the age of 60. And so it's a problem. It lands a lot of the older age group people into the ED with problems. Problems urinating, problems with backup of poisons in the system that aren't able to be filtered out through the kidneys, problems with the heart, and sometimes with the liver too. So let's dive into this. Okay, so the prevalence of kidney disease by age group with a focus on 65 and over is where we're going to start today. Renal failure usually follows stages of kidney disease, and I think Dr. Buka talked about the pre-renal, intrarenal, and post-renal stages of acute kidney injury. Now, chronic kidney disease is something that usually follows episodes of acute kidney injury. And long story short, enough insults on the kidney can lead to a chronic kidney disease. And like she mentioned, stage one, by the time you're over 65, we're all probably in stage one. But it's the stage 2, 3, or excuse me, the stage 3, 4, that the chronic and more serious kind of kidney injury is becomes our problem. So let me find my advancing tool here. Okay, so some interesting facts about the kidney. Oh gosh, let's see if I can move there we go, maybe up in the corner here so it's not in the way. Kidney disease kills more people per year than breast cancer and prostate cancer. Interesting. National Kidney Foundation recommends an annual kidney disease screening after the age of 60. Makes sense to me. And usually screening starts with at least some blood work and a urinalysis as well. Some risk factors for kidney disease would include things like hypertension, high blood pressure, whether or not you're dealing with diabetes has a direct impact on the kidneys. And kidney stones are also a big deal because those are considered a post-renal problem because they have a blocking effect on the outlet of urine or the output of urine through the normal channels. And they can also lead to other conditions like inflammation. And unfortunately, a kidney infection can also start from, kidney stones, especially if they're chronic. Someone with a history of chronic kidney disease is also at risk for further illness in that area. Prolonged use of over-the-counter pain medications. That would be medications like ibuprofen, naproxen, even aspirin in high doses can also have a negative effect. There are antibiotics too and other medications that typically in older individuals can be toxic, and that's the reason why certain medication levels are drawn while you're in the hospital to be sure that you don't have a buildup of those metabolites in your system because they can become toxic. And then just simply being over 60, just being in that age group puts you at risk. Like Dr. Buka mentioned, you get over 60, you're probably already in stage 1 of kidney disease. More than 37 million Americans, or 1 in 7, have chronic kidney disease and don't even know it. Yeah, and that's true. It's kind of like hypertension or diabetes. These go undiagnosed, unnoticed, untreated, until a doctor visit or something else worse happens. And you find out, well, guess what? You're diabetic, or you know what? You have hypertension now, and you have very high cholesterol. So a lot of this stuff is unknown until you wind up in the doctor's office feeling lousy or nauseated, unable to urinate. You feel cloudy, weird, confused. That's from buildup of toxins in your system. So there are over 120,000 Americans on the national transplant wait list. That's a lot of people. And more than 98,000 await a life-saving kidney transplant. which is also a very significant number. There are a lot of people out there waiting for a brand new kidney. Um, Needless to say, protect your kidneys. All right, let's move on. So, dehydration or hydration status itself, it plays a big part in kidney disease. Let me move this a little bit. In the aging population, and this information is from a book on gerontological aspects of nursing and healthy aging and healthy aging, rather, the title of the book that I got a lot of this information from. So dehydration for them is considered a geriatric syndrome that is commonly associated with many common diseases and also an individual's frailty, to be honest. Um, Dehydration is underappreciated comorbid condition that exacerbates a lot of exacerbates as an underlying condition in cases such as UTI, respiratory infections, worsening mental health signs and symptoms and disorders. It's associated with a significant risk factor for many other conditions and illnesses, including kidney stones, thromboembolism because of thickened blood, and medication toxicity. If you don't have enough water and fluid intake during the day, there's a chance you get a buildup of poisons, especially creatinine or urea, blood urea nitrogen, and other waste products that should be filtered out. And dehydration is such a problem in the aging populations in all settings. It's something that is basically it's a syndrome that's really underappreciated and not taken seriously enough because of all the kinds of effects it can have on the human body, on the especially the older individual more so than the younger individuals. Um, and it's a problem in all settings. It's not something that, oh, it's only individuals in, a care home setting where maybe they're having problems with uh, dementia or something else. No, um, this is a problem that crosses all areas of life for the aging population. And if it isn't, treated in a timely manner, um, well, it can at least contribute to an increased risk of death and mortality. So, what's the pathogenesis and relationship and its relationship to the body as far as dehydration goes and fluid status goes? Um, I think there are fewer diagnoses that generate as much concern um, about causes and consequences to the body as dehydration. Um, I know as a nurse, either as a primary or many times as a secondary condition, dehydration is an associated problem that's attached to kidney disease or especially acute kidney injury or acute kidney insufficiency or UTI. And I suppose that's why I chose these two things to focus on, these two conditions to focus on, because I've seen it so much. And I continue to see it as an instructor in a clinical setting with students. There may be a lack of understanding of how this works and the consequences of dehydration in the elderly population, which leads clinicians to sometimes come to the wrong conclusions, like I mentioned before, in regards to what dehydration might be attributed to. Um, it's rarely due to neglect, especially in a skilled setting and or an acute setting. It's not neglect. The majority of older people develop dehydration as a result of increased fluid losses or um, shifting of fluids, rather, as well, combined with decreased fluid intake. In other words, the drive to drink and take in fluids, okay, uh, as related to a decreased thirst, perhaps. It's rarely due to, nobody's giving this individual something to drink, or nobody's providing them anything to drink at breakfast, lunch, and dinner. It goes deeper than that. It goes deeper than what you might think, or what you might consider neglect. It goes much deeper. And I know that because I saw this kind of condition in my mother, who was in and out of the emergency department with UTI. So I put these kind of two together. Let's take a look at two of the most common kidney illnesses experienced by older age population, and also most impactful, and the ones that I've seen so often in the hospital. And I imagine if you talk to an emergency department nurse, they would probably agree that a lot of these individuals, granted they have other comorbidities, but they come in with a UTI or they come in with acute kidney injury. Boom. One or the other, sometimes both. So urinary tract infections, the signs and symptoms are kind of similar across the board. There's persistent urge to go and not be able to you have an urge to go, but not much comes out. Or sometimes it's painful to go, like you're peeing razor blades or pins and needles, or only small amounts of urine come out at a time. Maybe the urine, if you bother to look at it, looks a little bit cloudy, maybe even a little bit bloody, depending on what's going on further up in the urinary tract and the source of the infection. A blood in the urine is never a good sign. If you smell something malodorous or a foul odor in the urine, that's usually a very good indication as well. You could have a fever. We're talking about elderly individuals here. There may be a fever associated with it, or there may not be. There may be confusion associated with it. And that's related to how older individuals fight infection, and how these things show up in somebody under 60 versus somebody over 60. Infection has different appearances. Now, if you were to compare that to acute kidney injury, you can see that nausea and vomiting are usually present. Not always, but usually. Fatigue. In fact, with somebody with a UTI, nausea, vomiting, and it could be associated with that as well. Dizziness and weakness are also common with someone with acute kidney injury. Trouble with concentration, edema in the extremities, very good possibility. Maybe even extra fluid in the lungs as well. So fluid is going anywhere or isn't there at all. Or in the case of edema, it's not going where it should, which is into the circulatory system and out through the kidneys. So the mechanism, at least for urinary tract infection, is some sort of bacteria. It could be somewhere lower, might be in the lower urinary tract, bladder, urethra, or it might be somewhere higher. And typically, not always, but typically an infection can start lower in the urinary tract and find its way up all the way into the kidneys and into the functional units called the nephrons. And if it gets that high and you're dealing with a kidney infection, that's a very big deal, a very big deal. Now, usually the mechanism with somebody who's experiencing an acute kidney injury or insufficiency, you'll see, due to shock or perfusion, you'll see evidence of that by a severe drop in blood pressure, edema, pulmonary edema, edema in the extremities, um, uh, and you might experience poor perfusion of blood, period, to your kidneys, especially if they've been with poor perfusion long enough. Then some damage is done to the functional units, and to the kidney tubules as well, where a lot of, should say, secretion, water collection, and exchange of sodium potassium chloride takes place to either go back into the bloodstream and retain, or to go out and into the urine. If there are any obstructions, like say a kidney stone, or if there's some other form of blockage or abnormal, I don't know, a structural abnormality in the kidneys, in the tubules itself, it could lead to an acute kidney injury too. An enlarged prostate, because urine has a lot of trouble getting past an enlarged prostate. That can also lend itself to a bladder infection. And of course, there's the case of urine, I want to say kidney tumors or tumors of the bladder, anything that could block flow. And usually, getting back to urinary infections, the fact that what's associated a lot of times is poor hydration status. And again, if there's poor perfusion, tissue perfusion to that organ system, the kidneys, renal function, and there's poor hydration to those kidneys, there's a possibility of breakdown in those tubules that, where the formation of urine and either the uptake or excretion of, the byproducts of that filtration system takes place. If that's damaged or injured, it could lead to some permanent, it could lead to permanent kidney damage, or it could lead to a furthering, or I want to say not a furthering, but a more extensive period of time to treat an infection. Or you might have acute kidney injury and the infection to deal with at the same time. So yes, there's a lot of things going on there with both of those. But these two are the most common that I've seen when I've seen patients come in, elderly patients with these problems. Now, kind of in a nutshell, this breaks down what Dr. Bucaputnam mentioned last week about the different stages, and it's complicated, and I'm not going to get too complicated with this, but there are 3 stages. There's the pre-renal stage, and usually there's some sort of heart or liver disease going on, and of course there's the dehydration status. Now, if that's allowed to continue, there is the intrarenal stage, where either, post-infectious glomerulonephritis can set in, or you get some sort of what you could call vascular disease process setting in. Again, this is also part of what's going on, and this is where a lot of tissue perfusion problems are noticed. And you get a condition called acute tubular necrosis, Well, and they say causes to that, of course, would be things like sepsis. That's a severe infection, medication toxicities, contrast dye, and that's why um, either tests if they can be run without contrast, they do, or if they have to use contrast, they use as very little as possible because the toxicity will cause injury to the kidneys, very, very likely so. Another condition is rhabdomyolysis can do that too. A very, very prolonged pre-renal kidney injury. So what's occurring back here in a very prolonged stage can lead to the second stage intrarenal. Acute interstitial nephritis. Again, these are all, they're very complicated aspects to the stages of kidney kidney injury. Now, if it's allowed to get further on, if there are problems further on, rather, there's the post-renal phase where there's a possibility of urethral or ureteral obstruction. And usually this requires an obstruction coming from both sides, both kidneys or both ureters. Well, it could be something like a neurogenic bladder, which has a component, a neurological component associated with it. If there's a problem in the neurological system with the nerves that sense and also efferent and afferent nerves that work with the bladder and the brain or in the spinal cord to monitor that as far as not allowing such a large buildup of urine before we have to go and are able to sense that and empty our bladder completely. There's urinary tract infections that are recurrent. I want to say some that are lower down in the bladder, urethra. There's certain medications that have an effect on the bladder as well as the urethra. There's the benign prostatic hypertrophy. That's the prostate gland getting to such a size where it, it doesn't allow the passage of urine, or allows only a small amount of urine to pass. And if that becomes the case, urine slowly but steadily builds up in the bladder, and then it backs up into the ureters, and then backs up way into the kidneys, and you have hydronephrosis because of that. And that's a whole nother condition as well. So yes, acute kidney injury has these three phases, and they're all very complicated. And I want to say, hopefully, if it can be caught before it gets to stages 2 or 3, if it can be caught and dealt with in here, that's ideal. That's ideal. Now, here we go again with some, I pulled this slide out because I thought it was a good one, because it shows a somewhat elderly person with a cane and holding her printed out version of her labs. Some of the signs and symptoms, there's the oliguric phase. Oliguria meaning that you're not putting out very much urine, less than 400 mLs a day. And usually it's in the first beginning phase of kidney injury. Urinalysis is abnormal at this point, showing abnormal counts of certain constituents. You start to build up of acids in your bloodstream, so you have a metabolic acidosis going on. You become slightly hyperkalemic and hyponatremic during this phase as well, because there's an inadequate flow of urine out in order to pull and equalize sodium, potassium, and other ions going out through the urinary system. You get an elevated waste products represented by urea and creatinine. And because of this, you start to develop a certain amount of fatigue and malaise as a consequence. And that's a buildup of a consequence of a buildup of a lot of these poisons and waste products in your system, really. There's the diuretic phase, which is a gradual increase in urine output. Um, that can be, this is like a hospital phase I'm talking about here, where for the first couple of days, you might be putting out 1 to 3 liters a day, and could be all the way up to 5 days. But you got to be very careful using diuretics because they tend to pull a lot of water out of your system. And then also it tends to drop blood pressure significantly as well. But your waste products are making their way out. Your BUN, your urea, and your creatinine clearance are normalizing. Your glomerular filtration rate begins, well, recovery phase begins really, as I'm getting to that right now, begins when the GFR begins to increase. BUN creatinine levels plateau and then they drop again. So this is typical for signs and symptoms of acute kidney injury. Now, again, this is all very complicated, but by this, usually acute kidney injury is not treated at home. You are in the hospital for this. And just to hop forward a little bit, if a urinary tract infection is not properly treated at home, that will need to be treated with stronger antibiotics, fluids, and frequent blood draws and urinalyses while you're in the hospital recovering. Now, here's some stages of urinary tract infection. Instead of a top down, this is a bottom up because a lot of these infections start, toward the urethra. Pathogens colonize in the urethra and ascend to the bladder, which is where more colonization and population replication take place. And because they have a clear path of ascension, they head up toward the kidneys via the ureters. And this is where you get to a serious infection called pyelonephritis. That's the renal parenchymal infection that's got an inflammatory component too. And so that's a very serious infectious process that needs to be taken care of as soon as possible before further kidney damage is done. Now, in the end, bacteria continues to cascade up to the kidneys if it's not stopped, leading to acute kidney injury. Now, if it gets up that high from down below, you're in serious trouble. And again, if this is not taken care of while the situation is still in the urethra toward the bladder, then a visit to the hospital and monitoring fluids, antibiotics, medications to help control nausea, vomiting, because that's usually nausea and vomiting can be seen in both UTI and acute kidney injury because it can affect UTIs can get up and affect the kidneys and the whole tubular system and cause acute kidney injury. That's why those two are really together like that. I'm trying to step this up a little bit. I know I'm strapped for time here, but I kind of like this poster because it kind of, what does urine? Oh, shoot. Okay, well, that's all right. I got it. I don't know how to move that piece up top. So urinary tract infections in the elderly are common in both genders. So it's not just women, even though if you compare men and women, men have a longer urinary tract than women. Okay. And that's why women are more susceptible to urinary infections. Men, it's a more circuitous route to get all the way up to the bladder and above. And because of that, there's more of a chance of urinating and eliminating bacteria before it has a chance to colonize and reach the bladder. With women, it's a little different story, but that doesn't mean in the elderly that men are less likely. Men and women both are likely to have urinary infections as we age, both genders. And so this just kind of goes through some of the process of what happens, what's going on with the kidneys, where does it start, what happens with the bladder, what are some of the reasons why, maybe bladders are not our bladders are not emptied completely, because sometimes an unemptied bladder can lead to an infection. You have a pool of urine there and it's been in there long enough, it can colonize bacteria. And this is the reason why we don't like to put catheters in much anymore, because of the possibility of bacteria colonizing within the catheter itself, within the tubing and or the bag, and making its way back up through the urethra and into the bladder and up to your kidneys. So, this here goes through uh, things like hydration, avoiding, completely as much as possible, hygiene. I don't want to, it's a sensitive subject, but hygiene down in that area is very important when it comes to staving off urinary infections. And I want to say, worst case scenario, acute kidney injury. So the possible results, of course, what are some of the results? What could happen? Infection, of course, shock, worst case scenario when it comes to an infection, acute tubular necrosis. And the reason why that's bad is because in some cases it can be reversed, but in other cases it can't. And if that's the case, that could, destroy that kidney or part of the kidney, and basically that area won't make urine anymore and will be non-functional. So that's why that particular condition should be taken seriously. Damage to one or both sides of the kidney is possible. Thank goodness we have two, but you can get along with one. If one kidney is somehow damaged in one way, you can still function normally with one. You should know the impacts of a urinary infection and acute kidney injury are more severe in the elderly population. It has different impacts. I want to say one of the things it does is confusion is one of the hallmarks of a UTI, and it usually is too associated with acute kidney injury in the elderly. It's not that those signs aren't present in younger individuals, because they can be, but it's a good sign. It's a usual sign, a hallmark sign in the elderly population. Confusion, malaise, confusion, disorientation, dizziness, nausea, vomiting. Well, recovery can be hampered by the kidney's reduced ability to restore homeostasis in the aged population. And that's because, normally, and I talked about this in the first PowerPoint, as we age, functional units decrease. Instead of 1 million, we may have half that. Or not 1 million, 1 billion, we may only have half of that. Kidney shrinks some. The way the kidney operates changes. It's not as efficient. Um, Spotting the impacts of dehydration are not as easy in the older population either, simply because, I mean, you can't rely on things that we normally look at like thirst. You can't always rely on thirst. You can't always rely on dry skin, cracked lips, skin turgor. Um, you have to rely on other things, urine output. What are they taking in? Input and output, blood levels, renal function, urinalysis, microscopy of the urinalysis, and then other outward signs and symptoms as well. Signs and symptoms of infection. Worst case scenario. Well, there's dialysis. Dialysis doesn't always have to be permanent. A lot of times it is. And the worst of the worst is a kidney transplant. And as you saw before, you're dealing with, 100,000 people just on the list waiting to get a new kidney. That's a lot of people. Probably more than that. And a lot more than that who actually do need a new kidney but aren't on the list because they do not qualify for some reason. So urinary infections can be common and they can be chronic. So the more damage done to the urinary system, the more infections, more likely you are to be prone to yet another infection in the urinary system. And that was very evident in my mother, who it just seemed like every visit to the ED either had to do with a urinary infection or it had to do with pneumonia, one of the two. Now, my mother had CHF. Now, if you remember looking at that chart before pre-renal, people with CHF may also be at risk. If I can go back to that. There we go. Dehydration, heart failure, and then liver failure. There's that hepatorenal syndrome that I want to say those two, that the hepatic system is more of a metabolizing organ than it is a filtration organ, but that in the kidney and the liver work together very close. And so if there's a liver damage or liver failure, it can have a direct impact on the kidneys. Okay, so persons with indwelling catheters are definitely at risk. This is why we don't like to see indwelling catheters in the hospital and for very long, especially surgical patients. Get them out as soon as possible, decrease the risk of an infection. Untreated infections or any type of insufficiencies in the kidneys can lead to further damage, increased kidney damage in the end. And if we're talking about infections, we're talking about sepsis as being the next logical step. That's worst case scenario with an infection. Common reasons for recurring infections. Hate to harp on it, but these are individuals that don't take their medications as prescribed. They don't finish their antibiotic doses. It's more common than you think. It sometimes it's been known to lead to greater resistance to antibiotics by these pathogens. And AKI is a very complex three-stage condition. Infection and AKI can be connected. Not always, but they can be. Again, it's dehydration seems to play a part in both of those. You got to have enough. You got to have enough fluid in your system to run through those kidneys. You have to. You have to sometimes force yourself to drink water, even if you don't want to. You got to stay hydrated. It's a delicate balance if you have CHF, or if you have problems somewhere else with another organ system, like, for instance, the liver, because people with chronic liver disease like cirrhosis, fluid tends to move into different spaces, and they have their condition called ascites. And so that is a big deal too. So that fluid moves out of its proper spaces and into the abdomen, into other areas where it needs to be removed physically with a needle. So fluid volume is a big deal. Some medications with toxic effects can cause acute kidney injury, long-term of NSAIDs, or very high doses of NSAIDs. I remember when it was not uncommon to be sent home with 800 milligrams of Motrin, take every 6 hours as needed, and then Vicodin to go with it, which had 500 milligrams of, Tylenol, and whatever else for this pain, that pain, or some other pain. And back then, I used to think about stomach ulcers more than I did kidneys, and now I think more about kidney damage with so much ibuprofen at one time. Now I get leery when I see 800 milligrams of Motrin prescribed. In the end, age can play into this. Diabetes can play a part in acute kidney injury, especially when it comes to blood vessel and tissue perfusion and damage, vessel damage. Hypertension also plays into vessel damage. Dehydration, and I want to say blood clots to the kidneys are not all that common, but if you have clotting abnormalities, due to other reasons, that could make its way to the kidneys and basically cause an infarct to that area, or a stroke to that area of the kidney, or other forms of hemorrhage can also contribute to acute kidney injury. So this next caption, or this next picture here, shows all these connections. The arrows represent connections between, acute UTI, bladder calculi, renal damage from acute kidney injury, incontinence, chronic bladder wall damage, renal damage, chronic kidney disease, male erectile dysfunction, retention of urine. All of these are interconnected. All of these arrows show relationship. And that's why I included this slide. So treating these conditions, in the end, antibiotics, fluids, lab draws, urinalysis. These are typically used to treat acute kidney injury, maybe medications to control blood pressure, deal with diabetes in some cases. Seeing how much input and output, in a 24-hour period, maybe 24-hour urine analysis, So input output being strict, meaning how much in, how much out over a 24 per hour period. Managing pain, because there's sometimes pain, nausea and vomiting associated with this. Let's see. It does usually require a short stay in the hospital if it gets to this point. Electrolyte management is very important with someone with acute kidney injury too, because there needs to be a restoration of sodium, potassium. Too much of a loss of sodium and water can lead to, well, seizures. Too great of a retention of potassium can lead to abnormalities in one's EKG, and I want to say abnormal arrhythmias. Also, calcium levels need to be restored as well. Calcium is important to be in the bloodstream for several reasons, including it's used by nerves and muscle tissue as well. And vitamin D is also an important part of that. Now, dialysis may be necessary for a short time. Just depends on the severity of the injury and ability of the kidney function to come back and resume normal processes. So your stay at night might at the hospital might include things like telemonitoring, just to see if there's any changes in your heart while you're there, because there can be. Because again, the kidneys and the heart, like Dr. Bucaputnam, eloquently stated and so eloquently put a few weeks ago, they have a big impact. Kidney has a big impact on the heart. And I don't think I can overstate that. So treating UTI, well, it's geared toward eliminating infection through antibiotics, probably IV fluids as well, preventing sepsis above all. And in this case, sepsis being something that's in the bloodstream, sepsis, because an infection in one place can travel somewhere else, and we want to prevent that. So the moment we spot an infection, we're looking for other markers, other blood labs to see if infection and sepsis is setting in. We look for other outward signs like low blood pressure, high heart rate, high respiratory rate, altered level of consciousness. Use of antibiotics. If antibiotics aren't effective at home, then one must come into the hospital for stronger antibiotics. I want to say more closer monitoring, fluid restoration and balance. I want to say monitoring the kidneys to be certain that no further damage has been done. Also for things like fever and pain reduction. There's bladder spasm, associated with these conditions, it can be taken care of there as well. Bladder pain, that kind of thing. Pyridium's great for bladder pain. Oxybutynin is good for bladder spasming in that area as well. So we want to prevent this stuff. We want to prevent UTI and AKI. So manage your chronic illnesses, stay hydrated, keep notice of your input and output. What does your urine look like? How much? Any changes in your own temperature, mentation, confusion? Be assessed by your physician ASAP if you notice changes. If you catch a urinary tract, blah, blah, blah. If you catch a UTI early, you can get it solved before it becomes serious. And with acute kidney injury, um, blood labs will need to be drawn, serum creatinine, GFR, glomerular filtration rate. What are the other conditions you're dealing with? What chronic conditions or illnesses are you dealing with that might have an impact on the kidneys? Okay. Those should be managed before, they have a greater impact on your kidneys. That would mean liver disease, any heart disease, and surely managing, your intake and output. And then watch your ingestion of medications that are known to be nephrotoxic, meaning toxic to your kidneys. Pain medicines, I want to say non-steroidal anti-inflammatory medications are at the top of the list. Usually some antibiotics are also known to be toxic to the kidneys as well. So any questions? I can think you probably have a million questions regarding, wow, okay, what should I do if I see this or that? Or what labs am I worried about, the most? What should I tell my doctor? Should I report any kind of, back pain or flank pain, which is flank pain can be associated with either a UTI or acute kidney injury, both. Back pain, lower back pain may not be your spine. It might be kidney, could be kidney infection, acute kidney injury, might be associated with a urinary tract infection too. Nausea, vomiting, those kinds of things. How much fluid should you drink? Depending on the sources you go to online, they'll tell you different. Usually should have, from what I have read, and depending on the source you go to, I have seen 1.5 to 2 liters of fluid a day. And I'm not talking about soda pop necessarily, or alcohol, or coffee, or things like that. I'm talking about clearer liquids that, are not going to have such a diuretic effect. 1.5 to 2 liters a day at least, to keep the kidneys, to keep fluids going through them, to keep kidney function constant. Okay. And that's why people who are on diuretics need to watch, okay, that they don't get too dehydrated because of that. They have to strike up a delicate balance. Unless you're on a fluid restriction, then you have to really count and be very careful about how much fluid you take in. So I think with that, I'll go ahead and stop share. Terry's going to follow up on many of the lab values and their significance to both kidney injury, kidney status, and why are we seeing blood in the urine, maybe, or why is protein finding its way into the urine when it shouldn't, or why do I see white blood cells in my urine, or hey, how come the creatinine level according to my latest lab, is so high? So she's going to explain some of that in her presentation to you in the near future. Anyway, thank you very much. I had to pre-record this, and I'm saving it on a small USB drive to be used Tuesday. Anyway, have a great rest of your day. I'm going to go ahead and stop share now. Let's see. All right, stop share and stop